This is what happens. Oh,
What do I do? Okay, I
What?
have to close, or I have lots of things over here. I don't want to accidentally throw up something with the patient information.
Sure.
You. Okay, I think I'm getting ready now. Got it. I think it's taking me now online. I think we are live. What?
You.
What is going on?
Ready?
God. They
What?
just legalized it. I mean, do I have to be high?
Come on. You know I would not be
What?
high at work.
What are we
Okay.
even talking about anymore? Are we the problem?
No, I think you and I are on the same page.
I say sober as a button over here.
Okay. Go live. Go live or go home. Here we go.
What number is this? Because we've done multidimensional protocol like probably 3 or 4 times.
We have.
This part 4 or 5? You
Well,
think?
we are just going to mostly today talk about how we triage the patient, but you want to start?
Sure.
Yeah.
Hi, guys. Thank you for joining. This is Essence of Medicine. Today, we're going to be talking about how to triage a patient. My name is Amanda Armagast.
My name is Alyssa Haber.
And I'm Dr. Bassi from Essence. So, Alyssa, you and I, we are going to have a lots of conversation today.
Awesome.
And let's talk about first, how long have you been on the clinic side now?
Oh man, a couple months.
A couple of months. So, when the patient come to you, obviously you examine the patient, you
Mhm.
get the history and so on. But most of the time when they come to us, they're mostly for a main symptoms of, what's their main symptoms usually?
Back pain, numbness, tingling.
Yeah, pain is mostly
Pain.
the
Yeah, so
reason.
number one is pain.
Yeah, mostly the reason they come to us is pain. And have you had yourself spinal pain?
Oh yeah, I have.
Can you describe it?
Oh gosh, it's debilitating. It's terrible.
Oh,
My pain
yeah.
when I had my back, it was a dull pain, but anytime I moved, left,
Yeah.
right, side, it shot down
Yeah.
my legs. And yeah,
I,
back pain's not fun.
Mm-mm.
well, no pain is fun.
Well,
And I had to have myself back pain, even moving an inch.
mhm.
It literally, it has been that it took me 10 minutes to get off the couch, 10 minutes, 15 minutes to get in and out of the car. I mean, I'm a pretty pain tolerant person. Some people say I like the pain, but,
Yeah.
but this is a different level of pain. So when they come to us, obviously, we have to triage them. We have to find out there are certain things that you have to take action right away.
Mhm.
Most of the other things, they are important, it's painful, but they are not an emergency situation.
Mhm.
Now, do you want to tell what are the spine emergencies? What makes a spine situation an emergency?
Well, the first things I always think of are loss of bladder or bowel. So incontinence, meaning that we have lost
Mhm.
total ability to control that altogether. That's an emergency. The next one I think of some sort of weakness or acute change in weakness. I see
Mhm.
patients all the time with chronic pain that progresses into weakness, but we're talking like on the flip of a dime or over a course of a couple days, not being able to, walk, foot drop, any sort of dropping things out of their hands, those sort of things.
Yeah, and you practically summarized things that I think everybody should know. Number one, bladder bowel incontinent, but imagine I'm the patient, I'm coming to you, oh, I have been incontinent for the 5 years, or
Mhm.
it comes and goes and so on. This is not what we are talking about, right? You're
Right.
talking about that patient all of a sudden become incontinent, and that's not like just soiling oneself or
Mhm.
letting it go. That's the not feeling that you are doing it.
Correct.
Okay, and that is very different because everybody in pain, especially elderly, they have urgency and so on, and they are in pain and they cannot move fast enough, and they just, they just let go. This is not what you are talking about. You have to be able to distinguish between this urgency, this incontinent come and go, that then acutely, like within 24 hours or so, patient become incontinent and they don't feel that they are soiling themselves.
Mm.
That becomes an spine or neurosurgical emergency. Why is that? Let's ask Amanda. Amanda, why do you think if somebody all of a sudden cannot feel that they are soiling themselves, why do you think it's become an
I'm just gonna wait.
Oh, you guys are locking up. Maybe I'm locking up.
Yeah, I
we're
think
back.
we're back. I think that in my opinion, it would be an emergency because it's something that's all of a sudden and it's not like a gradual thing.
Yeah, actually pretty good. Everything that happens so acutely it's had something underlying problem that is very massive. Because our body compensates for so many different things. Things that happen acutely has to be looked at acutely.
Mm-hmm.
Okay. And another thing that you said, the acute weakness, that's actually pretty good. Now, the going joke among neurosurgeons is that if you give one case to 5 neurosurgeon or spine surgeon, you get 7 different opinions. But anything with a bladder bowel incontinence, acute onset of weakness may indicate massive pressure on neurons or instability. Both of that, if not taken care of, may become permanent. Mm-hmm. And that is the point. They may become permanent if you don't deal with them right away. In that sense, I want to share my screen with the multidimensional protocol right now with you that will summarize practically what we just talked about.
Mm-hmm.
Are you able to see that?
Yep.
So patient comes and it's zoned in our protocol, zone 1 or zone 0 is patient hit the door, goes to surgery, bypass everything, no conservative therapy, no EMG, no blah blah. Hit the door, goes to surgery. But that is red zone, and the red zone, as you see on that side, on the other side, progressive deficit, and then that progressive deficit is not enough that patient has progressive deficit. It has to be incontinent or acute weakness. Now, acute numbness and tingling, it has a value, but it automatically go to surgery.
Right.
But protocols as well, as you see, red on the symptom side has to correlate to the red on the other side. What does that mean, Alyssa? When your patient come as progressive deficit, which is weakness, let's say,
mm-hmm.
What is the first thing you do?
Call you if I see a red case like that.
Yeah, definitely. But look at the other side. Look at the other side.
You go to get some imaging. I mean, you do your history, and you have to then correlate what they're saying with some sort of imaging. If they came in with bowel, bladder incontinence, bowel, we go probably typically to an MRI, a stat MRI.
Sure. No, well, let's look at that. Let's talk about that. If the patient comes, has progressive deficit, has weakness. Now, you called me already. Mm-hmm. What's the first thing I'm going to tell you?
Get imaging.
Get imaging. Which imaging do you get?
I'd get an MRI for this patient.
You get the one that you can get fastest.
The fastest. Okay, well, typically that'd be a CT, but yeah.
Yeah.
Sure.
You get the MRI that gives you, what are you trying to look at? What is why is it that we talked about that? Mm-hmm. It's massive pressure on the nerves, or instability.
Right.
So what are you looking for in those images? Let's say start with the X-ray.
Well,
What could X-ray show you?
X-ray could show us some sort of fracture, some sort of mass, some sort of, anatomical. Anatomically speaking is typically what you.
Sure. I know if you can get it, it's the fastest you can get.
Mhm.
Is it in 2023? Is that good enough?
Typically not, but
No, it is not. It's not good
not
enough.
gonna roll in or out, our big problem here.
MRI is always a good idea if you can get it fast enough, but CT, you can get it in 3 minutes.
Right.
Okay.
Exactly.
So CT is always and that's why when somebody like that comes to the ER, usually the first thing they get CT and then schedule the MRI, but they get the CT.
I'd agree.
Okay. Now, what is do you want to? There's something that says CT/myelo. Do you want to say what that is?
Well, the CT is obviously, we talk about the CT, and the myelo would be the myelogram, which is typically where they would put contrast. That's with contrast. And then they run you through a CT and you're able to light up the spinal cord more specifically and look for myelopathy, kind of the
Would you
damage.
see myelopathy on the CT myelo? You see the names are very similar. What does myelo means? Myelon. What is myelo?
Myelin sheath, the spinal cord.
Well,
correct.
actually, myelon is the word for spinal cord. Okay.
I think that's what I said.
No, you said that myelon sheet. Myelon sheet is something different than myelon.
Okay.
I think is something covering your mic? Your sound is really coming in and out a lot.
Okay, well, my connection is not good enough here.
Sure.
Maybe. Okay, well.
I'm with you. The spinal cord.
Yeah. Now the myelin sheet is on the individual axonal level, where that myelinization of the axon, where it gives you those Ranvier nodes that jumping and so on. But okay, let's go back and talk about the CT myelo.
Okay.
CT myelogram, where we put a contrast in and we let it go around the nerves, and then we can see the nerves in CT. Because without this contrast, we cannot see the nerves very well.
Mm-hmm.
Now, there is all of that is a little confusing because there is a picture, pathological picture, we call that myelopathy.
Mm-hmm.
Surprisingly, you cannot see myelopathy in myelo-CT. You can. Why?
Because you told me so. That's always a good enough
Always a good answer. Always a good answer. But
thank you.
Yeah, good one.
Myelopathy is when the nerve cell in your spinal cord die.
Okay.
Spinal cord is myelin, and myelopathy meaning disease of the myelin, of the spinal cord, where the cells die. It is within the spinal cord. What that means, the contrast doesn't get there to show it. It is inside of the spinal cord. So you see still the contour of the spinal cord, but you cannot look inside. So myelopathy is as well an emergency, but is not something that automatically take you to surgery right away, okay? But let's talk about that because that is the third thing that is extremely important, myelopathy. You want to tell us what the clinical signs of myelopathy are?
Well, myelopathy is typically something that, when I think of myelopathy, my first thought is something that impinges on the spinal cord, whether that's a tumor, some sort of, infection that gets into the spinal cord. So then the symptoms would be based upon what's causing the myelopathy. So you'd see some of those symptoms that we talked about. Like, oh yeah, I'm ready.
Very good answer, but let's dissect. I want to see if you are aware of the consequences of every word you said. Something pushing on the spinal cord.
Okay.
That's something. Does it have to push from outside, inside, or both?
Does it or it doesn't? What was your
Tell
question?
me, when something push, your word was when something push on the spinal cord.
Okay.
That something that push on the spinal cord, does it matter what it is?
Well, I mean, yeah, it matters what it is.
No,
But I
for
guess by
myelopathy, it
definition,
doesn't. For myelopathy, it doesn't.
no. I said by definition, no.
No, everything that push on the spinal cord can cause myelopathy. Does it have to push from inside or outside of the spinal cord?
I would guess
Doesn't matter.
Oh, doesn't matter.
Anything, no, anything that push on the spinal cord can cause spinal cord the cells to die and create a myelopathy picture. Now,
Okay.
and you said pushes on the spinal cord. That is, let's dissect what is the consequence of that. So, let's say that you have a tumor in L4. Does a tumor in L4 can cause myelopathy?
Yes.
It can. Explain.
Because you just told me that anything that applies pressure to the spinal cord can be
You
cause
see, you
myelopathy.
told the right thing.
Therefore, a tumor
told the-
that presses on the spinal
Mhm.
cord absolutely can
Is it?
cause
Is there
myelopathy.
any spinal cord at L4?
Well, there's not. Stop. No, you're right. It ends at L1. I know.
No, you could have hit
I
back
was
at
so
me.
zoned in on, I go, no, myelopathy is anything.
It was a trick
Ah,
question. He said
It
you
could cause some chronic
Yeah.
blindness.
Right, but Alyssa, you could have bounced it back at me
You're
and
so
said,
right. It's 4:30, guys. Give me a break. I just had
okay,
a day.
listen. You see, you will never forget that now. But
Oh, I will.
hear me out.
I
now.
100%
You-
will. I know
you
the
could
answer.
have you could have hit back and told me, yes, there is in an infant, there is spinal cord at L4.
There you go. Oh,
You know-
I would not have hit you with that though.
No, but that's true. See,
Okay.
when we are born, our spinal cord goes all the way down to sacrum.
There you
But
go.
then spinal cord grows slower, much slower than the bone, meaning that it retracts. And when we are an adult, for all practical purposes, when we are teenager or 10 years old, our spinal cord stop at what level?
Typically L1.
L1, 2, correct. So what that means, you said the right thing. Anything that pushes on the spinal cord can cause myelopathy. But below L4, below L1, 2,
Mhm.
is nothing really in an adult generally pushes on the spinal cord. So below L1, 2, you get a picture of a second motor neuron compression, claudication. Above L1, 2, you get the symptoms of the first motor neuron, myelopathy. So myelopathy comes in two things. There's a radiographical myelopathy where you get an MRI, you have hyperintensity within the cord. In the T2, you have white inside of the cord. That's a radiographical myelopathy, but then there is a clinical myelopathy. Do you want to enlighten us what a clinical myelopathy is?
Well, based off what if clinical myelopathy would be basically taking the symptoms and history that you get from a clinical side of things and making that diagnosis without the radiographic. That would be my,
Is the symptom of the first motor neuron.
from a clinical side. Yes, correct.
Let's go back to our anatomy, neuroanatomy. The first motor neuron is on our cortex, right?
Okay.
It goes down, it goes to the decussation, meaning that crossing over,
Mm-hmm.
goes down segmentally, connect to the second motor neuron, and that second motor neuron goes all the way to our muscles. Like when you're moving your toes,
Mm-hmm.
there are only two nerves involved in that. Well, there are billions of neurons involved, but the path requires two motor neurons from our cortex all the way to the muscle, and they cross over segmentally. Now, I say segmentally, but we understand that the practically L5 segment of the spinal cord is at T12 bone segment, correct?
Correct.
Yes. Yes. Does that make sense so far? So
Yeah.
if something push on if you have a big tumor in T10, T11, T12, you get the symptoms of any spinal segment that is there of the first motor neuron, and anything that's after that second, anything that above that second motor neuron, like a tumor at, let's say, a tumor at T10 bone. When we call the tumor in our body, we always refer to the bone. But a tumor at T10 is practically pushing on the nerve cells of the L4-5S1.
Right.
So for the L4-5S1, you get the symptoms of the first motor neuron. For anything that's above that, like for other things, L1, 2, 3, the motor neuron already has crossed over. You get the symptom of the second motor neuron. That is how old neurosurgeon and neurologists, without CT, without anything, they could be diagnosing where that problem could be to cause certain symptoms. Like, even that becomes even more difficult or more intriguing, because certain quality like sensory or motor, they cross at different location. So I'm not going to talk of that, but a neurosurgeon must know a disease called Brown-Séquard syndrome, where you get the sensory deficit on one side, but the pain and burning temperature on the other side, because they cross at different level and so on. So let's not go there, because today we are just going to talk about, we are going to make it easy. We are going to talk about multidimensional algorithm that, so patient comes with progressive weakness, you call the neurosurgeon, but then you get films that you can get the fastest. And then if patient has myelopathy, then you're still going to do all the same, but it's not an emergency. Now, let's go back, talk about what are the symptoms of clinical myelopathy and what are the symptoms, which is practically the symptoms of first motor neuron. Amanda, have you seen anybody with a stroke?
Yeah.
Stroke is generally, has symptoms, practically a damage of a certain area of the brain. So it gives you many symptoms of myelopathy, but on top of that as well, symptom of the cranial nerve, because it is all the way there. Myelopathy is practically almost like a stroke of our spinal cord. Like, have you seen somebody with that, if they have a stroke, when they walk really funny. So one of the biggest problem of myelopathy is ambulation, balance, walking. So if you see somebody coming and he cannot walk recently, that is very concerning. So what is a typical myelopathic gait? How does a person with a myelopathy walks? What is special about that? Any guess?
Not off the top of my head. I mean, my
Well,
first thought is shuffle,
let's-
slow. Are they
Yeah,
gonna be
my-
slower, short
Mhm.
steps, shuffle gait?
Yeah, my first
Yeah, all of that. But no, let's do an experiment, all of us. Okay, you do that. I know it. I won't do that. Now
Okay.
close your eyes. Both of you, please. Now lift up your both hands and touch your index fingers on each side together. Both of you, touch your index fingers together. Amanda, touch your index fingers.
Oh, I thought like we had to touch them.
Yeah, touch your index finger together. Were your eyes closed when you did that?
Yeah.
Good. You can open your eyes now. How does your body know
Will you ask that again?
Now, how does your brain know where in space to bring those two fingers together so they meet?
Different receptors in our bodies.
You have receptors in your body, joint receptors. The joint receptors in your body tell your brain where in space. Like there's another note I do sometimes with students. Make a very very funny mode. Close your eyes and make a very funny posture of your hands or fingers.
You want us to do that as well?
Yes, do that. Do that.
Okay.
Like no, like this. Like it's something funny. Really, you have a mental picture. See, look in your brain. Close your eyes. In your brain, you have a mental picture of what you just did.
Yeah.
And if I take a picture of it and you compare it to your mental picture, everything will be exactly that way. You can put that under. Does that? But you understand the only way your brain knows exactly what kind of funny posture you made in the space is because you have joint receptor in every single joint in your body, and your brain take all the information, put them together, and make a replica in your brain of what funny picture you made in the space. Now, in the myelopathy, you cannot do that anymore. What does that mean? Somebody with myelopathy has to look with their eyes exactly where they are, where the feet are, to compensate for the lack of joint receptor. Do we have another name for the joint receptors? We call that proprioception. Exactly. So in myelopathy, the proprioception is disturbed. Somebody with myelopathy walk funny because he's looking all the way where the feet are. He's compensating for that. So another thing in myelopathy, first motor neuron. Amanda, have you ever seen somebody with a stroke, how their joint look like, how their motion look like, and so on? Have you ever seen anybody with a stroke?
I mean, yeah, I've seen people that have had strokes, but I haven't really I'm sorry, what was your question?
Can you describe what you saw?
Yeah. A lot of times, I mean, it's not that I've seen so many people that have had strokes, but like maybe half of their face is a little bit frozen and
weakness. Okay. What else?
And maybe they have a hard time grasping things.
Yeah. Have you seen sometimes that they grasp something, but they cannot let it go?
It's a kind of a hallmark sign that I've noticed with some of my older patients when I worked in the nursing home is that they'll typically have their arm curled in a ball, and a lot of times they'll keep it close to their body, and it does that same sort of, curling thing that we kind of see the body's reaction. I know there's a word for it. I don't know.
Spastic paralysis.
Paralysis, yeah.
Yeah, but that is a later kind of sequel of a stroke. But there is an early part of the myelopathy or stroke, clonus. What is clonus?
It's almost like the seizure-like moment, like the twitching moment back and forth. I don't not very good words to describe it, but it's typically mentioned with seizure activities. Clonus.
You want to tell us how you examine a clonus?
Do you want to tell me how you examine your clonus first?
Like I'm going to have to ask them to not do the biceps, and I'm pushing against that. They contract, let it go, contract, let it go, contract, let it go. Okay. That's the clonus. Another sign of first motor neuron problem is so-called hyperreflexia. I think that should be easy to understand for everybody. Every muscle in our body has a deep tendon reflex, and if they are overactive, then that's usually a sign of first motor neuron problem. Now, how do I know, Alyssa, if it's hyperactive, if it's hyperreflexia, or you're just excited to see me? How do I know that?
Well, if we have a baseline, it's always good to know what the baseline is. If it's a change from the last time that you did it.
But maybe you weren't last time excited
I
to
say,
see. Maybe
oh,
you
okay,
are
I'm
now
always
excited
excited to see you. From a physical exam side of things, I always kind of hit my hammer on the reflexes the same all the time. Based
Yeah.
on looking at patients, you have kind of an example of what you expect to have as a normal, well, 2+, what we call it normal.
Yeah, 2+ is normal, 1+ is normal.
Right. So we have a scale, you know, and for that reason that there's a difference between a 3+ and a 4+ when it comes to hyperreflexemia, you know, so.
Yeah, well, if it's a 4+, you just barely touch it, it jumps.
Mhm.
That's easy to find out.
Right.
If in doubt, compare one side to another and compare upper extremity to lower extremity. If you want to be like an old neurologist, nobody really does that anymore. You use the masseter reflex as a standard candle. Okay, but that is too far. Let's not make it complicated. Let's make it easy. So, patient comes, let's say it doesn't have progressive deficit, it doesn't have incontinent or acute weakness, and we talked about the myelopathy. As myelopathy, you still call me, you still get the films, but you don't call Army and the Navy and the Air Force and so on and so forth. You get it within a reasonable time frame. It is not red anymore.
Mm-hmm.
You see how easy it is? Just pay attention to that. If somebody comes with without those red parts, but myelopathy, you get it within a week. You get it within 1 to 2 weeks, but you don't have to stop everything else and just deal with the emergency thing. Mm-hmm. What does that mean as well? That patient is not the automatic red zone.
Right.
Okay. So that gives you some time. Now, we talked about the myelopathy. Now let's talk about weakness, chronic weakness. I mean, subacute chronic weakness. You see, that comes next.
You say acute on chronic weakness is next. Is that what you had said?
Well, you know, the patient comes, it's not acute, meaning it didn't happen just in the last few days.
Right.
So you can't, well, it can be happening that within a month or two, that is sort of quasi-chronic, but if it's years, that's definitely chronic.
Mm-hmm.
Either way, it is not the acute weakness. But now that we are talking about the weakness, let's talk about the weakness. How do you know if somebody is weak or not?
I'm gonna give you the same answer I gave you for the hyperreflexemias. Is of course you have a baseline, you check it out. You, like you had said, you go from one side or the other. We do strength testing, typically resistance testing, to give them a scale on 1 to 5 based on how they line up for us.
Describe the 1 to 5 scale.
So we even put some pluses and minuses in there as well. So basically,
about the plus and minus?
a 5 out of 5 would be, you know, they have full strength intact. And then, you know, you would go down 4, 3, 2, 1.
I think my connection wasn't good, so I didn't hear that. Can you repeat that?
Yep. I said basically 5 out of 5 is the best we can get. And it goes down based on their lack thereof strength or weakness that we see, down 4 being, you know, just slightly under full strength, 3 being about 50% strength, 2 being very.
We don't use that 50%.
Right.
So,
no, I would agree. That's just my trying to explain the order in which it goes.
Let's do the easy part.
Okay.
5 is full strength, 0 is totally paralyzed, and 3 is anti-gravity.
Okay.
Okay. So imagine my hand. If I can lift it against the gravity, but nothing else, is 3.
Okay.
But as soon as I touch it, it goes down. But by itself, it can go against the gravity, right? So we got 5, we got 3, we got 0. 1 is easy. You see this twitching, but really nothing really moves.
It's trying, but sure.
But you see it, but it really does nothing. You see twitching, but nothing really moves. 2 is that it's not against the gravity, but when you eliminate the gravity, it can move. And 4 is obviously between 5 and 3, right? And don't even bother with the plus or minus 4 and so on. If it's not full, but it's more than anti-gravity is 4.
Okay.
So make it easy.
Yeah.
Now, let's talk about the muscle segments. We have hundreds and hundreds of muscle in our body, but we don't check all of them. We check them, we check segments, we check muscle that give us important information about certain segments. And they as well, they're easy to check. Like, who's going to check the obturator muscle? That's not easy to check. We check muscles. Well, some neurologists could do that, but you and I, that's beyond us. Check the muscle that are easy to check. Right. You want to tell us what those are?
Typically we do our deltoid, our bicep, our tricep.
Deltoid. You say it and I do it. Deltoid.
Okay, so yep, I do our deltoids. I do our biceps.
Biceps.
Yep, we do our triceps.
Triceps.
And then I do grip strength.
Grip. Okay, what else?
Wrist extension flexions.
Yeah.
Yeah, I know those aren't muscles. Those are the main ones that I.
So deltoid. I mean, you can go, and the reason I'm saying that is because there are segments that are very representative, like deltoid is C4. Forget about that even. So, but check the deltoid, biceps, triceps, grip, lumbricals.
Okay, interosseous muscles, yeah.
And
there we go.
Thumb opponent, not this. This. You pull the finger through. Okay?
Okay.
So that was upper extremity. What about the lower extremity?
Do the same type of thing. We hit each muscle groups. We are checking for our, I guess technically, I think hamstrings, quads.
No, go proximal to distal.
Proximal to distal. Well, the first thing I do is this. I don't even know the right words. I have them lifted up and I resist on the straight leg up.
Well, so, iliopsoas is the first. Iliopsoas, it is, you let the patient sit and ask them to bring the knee up.
Yep.
Okay, that's iliopsoas.
Thinking the same thing.
No, straight leg raise, making the leg straight and bringing it up. The combination of many.
That's a test, correct?
Yeah, that is a straight leg
that's
raise.
That's not what I was talking about.
Yeah, so the iliopsoas is important because it's upper lumbar spine. Then, what is the big muscle in front of your thigh?
Well, we got our quadricep.
Quadriceps, exactly, where patient is sitting, one leg at a time, make it straight. They keep it straight, you try to bend it. What's next?
Hamstrings.
Hamstring, they keep the knee bent, they keep it bent, and you try to pull it and straighten it. Now, how many times, if I ask the patient, can you please bend your knee? And they ask me what direction. And I want to just take hit my head against the wall. I say, how many ways can you really bend your knee? If you bend your knee the other way, oh my God, I would be very concerned if you could bend your knee from the straight the other way up, Yeah. So bending the knee is the hamstring, right?
Correct.
What else? Let's go down.
Then
muscle.
Huh? What was that?
2 or 3 more muscles.
Yeah, you're gonna go to the calf. So what? Gastrocnemius or soleus?
Gastrocnemius. Okay. Just tell me, how do you check gastrocnemius?
Doing that same. I do the same sort of resistance on having them kick their legs out, and I am pushing at the same time.
Not the leg.
Okay. Well, I haven't got there. Sure. So have them push down while you're resisting up, and then have them point their toes up. Down.
And then what next?
I don't know the names specifically. I know you're going to have them point their toes up and down.
Tibialis anterior.
Okay, there you go. That's on the front of our tibia. There you go.
And if you want to be very, very fancy, you check another muscle called extensor hallucis longus, EHL.
That's the big toe, right?
Big toe, yeah.
Yep.
Extensor, hallucis is the big toe, longus,
Yep,
the long muscle that goes to the big toe, the
right.
Latin. Okay, well, now, but I think it's important that if you ask somebody to examine somebody, I say, I ask, for example, Alyssa, what is the motor exam of this patient?
Sure.
But you understand that you and I are talking about the same kind of, understanding that we just discussed. The answer is not, yeah, it's a little weak here, a little here and there. No, the answer is, to be honest, here on the left is 4 of 5. All the others are 5 of 5. That is the right answer. The non-professional answer is that, yes, sometimes some of the muscles are weak. And so that is not really what I'm looking for. I'm looking for because if it, to be honest, anterior on the left is weaker, that indicates L455S1. That has clinical consequences. Okay, well, we got the muscle exam. And you see there that after weakness, it comes reflexes. We sort of talked about that. We don't have to go there anymore. Claudication. Let's talk about claudication. What is claudication?
Pain with walking is always my basic term that I start saying to people when they start moving and they get the pain build up in their legs, whether that's from blood flow, whether that's from fluid buildup.
Well, this is a word that we borrowed from vascular surgeons, okay? Because they have something they call claudication, meaning narrowing of the arteries. Okay. So when patients start using the muscle where they need more blood and oxygen, they just don't get enough, then the leg become heavy, become painful, they cannot use them. They call it claudication. We call our thing neurologic or spinal claudication.
Okay.
Where something is pushing on the spine. Again, do you remember that? Below L1-2, because above that, it would be myelopathy. Below that is a claudication, push on all those nerves and impede the function of all the nerves. Because if it was pushing on one nerve, it would not be claudication, it would be radiculopathy.
Correct, just one.
It would be segmental. But if it's in the spinal canal, something pushing on all the nerves and that location below L1-2, then can impede the function of all of them. By the way, what do we call all those nerves below L1? They go down like a tail.
I know what it's called. You know what this is called. I've said it before today already.
I don't know.
Tail of a horse.
Yeah, it's cauda equina.
Okay.
We say it all the time, but yeah, it's horse tail is what it literally means,
That's
right?
Correct. That's correct.
Real original there.
Yeah, all description are from just Latin and Greek. That's how we borrow all the anatomical names. So practically, claudication is when patient, after a certain amount of standing or walking, they just can't anymore. Pain, just lose strength or whatever, they just can't. And so that is as well important because that indicates there is a spinal canal stenosis below L2 or below L1-2. No, and then pain, obviously. Pain is important, but why is it pain after all the other stuff? Alyssa, what do you think, why is it pain in our protocols, not the first thing on top?
Because pain is subjective. Is that possibly why it's so low? I mean,
very correct.
I say we could come up with pain or exacerbate pain in any sort of fashion. We talk about how, quote, pain is in your head. And we mean that. So, and we mean that on this level too, is we can't measure your pain based on just what you measure based on what you tell us.
Well, a 10 to me is way different than a 10 to him.
Right.
So that makes a lot of sense.
Well, sometimes you two give me 10 plus 10 pain. You too, yeah.
Yeah?
You give me
Is
10,
that so?
you give me 10, I still laugh it up.
Well,
So
thank gosh it's on the bottom of the list because he'd be in
yeah,
surgery.
you see, that is exactly why it's on bottom of the list.
Jeez.
Because it is not something that you can quantify. Like, how many times do you see a patient, they smile at you and they tell you their pain is 9 out of
10
10?
out of 10? Oh, you're
Meaning,
being nice when you say 9 out of 10. I
Yeah.
can think of a couple that we've had in the last couple of weeks after surgeries that smile, say 10 out of 10, then fall asleep.
yeah, but
And I go, yeah.
you know what that is? 10 is supposed to be a woman giving birth to a baby during the labor. So you are telling me, you're smiling at me that you're giving birth to a baby right now, that
Yeah.
your pain is that bad. But and that you understand why is it toward the bottom of the list.
Right.
Mm-hmm.
Okay. And then you have sensory deficit. And sensory deficit as well, make it easy for you. In all our rooms, there is a chart
Mhm.
for dermatomes.
Mhm.
Just take a picture of it. Don't try to, and even make it more easy than that. Describe where it is. Don't try to say L4, L5 if you know
Mhm.
exactly. See, if you know exactly that is L4 and L5, you can pick up the phone and say, Bossy, patient has left tibialis anterior 4 or 5 weakness and left L5 dermatomal radiculopathy and sensory deficit.
Mhm.
But if you are not sure, just describe it. It is pain is in the back of the thigh or anterolateral of the thigh, top of the foot, side of the foot, heel, toes, front of the on the shin, on the calf, on the back of the calf.
Mhm.
Describe it. That everybody should be really able to do. Right?
Yep. And you're right. We have myotomes and dermatomes, I think, in each office and maybe even in the PA office too. So
Yeah, don't become too fancy, It become fancy. You tell me L4, I say, okay, L4. But actually, no, that it becomes fancy or misleading when you tell me it's L4, but with that you mean front of the thigh. Then it is not
that would be
L4.
bad.
Yeah, well, then it leads me to the wrong path. But
Correct.
if you say,
That's pretty
if you say-
detrimental or could be detrimental.
yeah,
Absolutely.
so don't be fancy and don't, I've been a neurosurgeon for a very long time. Until just recently, I still look at the charts. Is no shame to look at the charts. And
Double check.
not only that, we are not robots. I mean, some of us are, but there is absolutely nothing wrong having those charts or describe it to regular words. If you're not sure about the actual, the graduation and numbers, dermatomes, and so on and so forth. But now let's come to the other side. Let's say the patient comes, no progressive deficit, no incontinence, no acute weakness, mild weakness, no reflexes are all right, some claudication, obviously some pain, and some sensory deficit. Let's triage this patient together, Alyssa.
Okay.
What do you do?
Based off of what you said, strictly, I haven't noticed any sort of symptoms that warrant me to even bring him close to the surgery consultation at this point. So my first thought is always we're gonna do the first steps, which is typically, for me, it's always physical therapy. Now
We get some films though, right?
Oh, sorry. Yes, I thought we were just on that part. Yeah, sorry. Yep, we wouldn't have to be. Sorry, I was thinking we were just on the PM&R management side of it.
Let me make it easy for you.
Yeah.
If anybody comes with radiculopathy or
Okay.
weakness or sensory deficit,
Mhm.
you have to get a film that you can look at the nerves.
Okay.
There are 2 films that can look at the nerves. Myelogram or MRI.
Look at me. I see Milo up there. My first thought was myelopathy. A myelogram. Yeah. Myelogram and MRI. Yep.
Or MRI. Which one does a BOSIP? Not they are the same for that purpose. They are the same, but which one do I prefer?
A myelogram, I'm guessing.
Why do I prefer myelogram to MRI?
Because then you're able to see the actual spinal nerves in detail and see where the deficits are at specifically. I mean, I think you have a better image of what you're working with.
Yeah, no, you would see the actual nerves in MRI actually even better.
Okay.
That's not the reason. But what don't you see in MRI is if you have, let's say, somebody had a fusion before, there's a
Okay.
metal there. Not only you don't see the metal, wherever metal is, you see a shadow. You don't see anything at all. As well to look at the bone structure, CT is much better.
Right.
Even more. The regular MRI is a grid of 256 times 256. The grid of the CT is 512 times 512. So by definition, a CT has 4 times, not twice, 4 times the resolution of MRI, and even get better. MRI has lots of spatial distortion, meaning just the edges don't work well because the way it's produced, the physics, I'm not going to bottom of it. But CT has much less spatial distortion.
Okay.
So I always measure the size of my screws or size of the hardware I'm going to put in the CT, not in MRI.
Okay.
Okay, so, but it's MRI is nothing wrong. So let's say patient comes, has what this symptom I just described, has an MRI.
Okay.
And what is important about that MRI? What is that? When do you get a new MRI and don't you get a new MRI?
Well, I know that you typically like to have an MRI within a year of performing some sort of surgery.
Very good answer. Very good answer.
Or if
Okay.
some sort of change has occurred since the
Bingo.
last
Bingo.
MRI has happened.
Okay. Let's say they had an MRI just a month ago, but they start being weak last week.
Yeah.
There
Correct.
you go.
You would need an updated.
If the symptoms they are presenting to you is something that happened after that MRI, you have to get another image that shows the nerves, another myelogram or another MRI, whichever you can get better and faster. And if they have previous hardware, I still prefer a myelogram because then I can see more.
Correct. Gotcha.
Now, X-ray, when do you get X-ray?
The only reason I think to get an X-ray is if we have some sort of, fracture is the first thought, some sort of fast on the spot or, fall, you want to check hard. Not even then, but it's the fastest, most cost-effective imaging that we probably have. No,
It
not
used to be, not anymore.
Not anymore.
You can get in 3 minutes, you can get
SCT,
faster a CT than you can get an X-ray.
Right.
No.
I'm with you. I say typically for
Two
us.
reasons.
Okay. What are they?
Number one, if you want to get a whole picture of the spine to measure the scoliosis while they're standing up.
Okay.
Number two, you ask them bend forward and bend backward to see if they have a mobile listhesis or if the listhesis is like this listhesis, if it stays the same when they bend forward and back.
And that makes sense. That makes sense,
Yeah.
especially why would we use an X-ray for?
Yeah. So, but practically everybody needs, so literally one of the major things you do, you get flexion extension X-rays.
Okay.
X-rays, it's important to know if they have a mobile listhesis or not, or MRI. And then that is good enough to send the patient to me. But instead of MRI, you can get a CT myelo, which I do prefer. And the advantage of that is then when I see the patient, I'm not going to go back and order a CT because let's say patient get an X-ray, MRI, and now I'm thinking about doing surgery, I always will get a CAT scan. Always. So many times I get an MRI shows me something, and then when I get a CAT scan, I see a piece of bone there that is sticking into a spinal canal. That changes the surgery completely. Okay, so it's not wrong to get an X-ray and MRI. I will order CT anyways later, but even better to order a myelogram, then I'm done. I'm ready to make a decision with the patient right there.
Yes, perfect. Good to know always.
Let's talk about discogram. When do we order discogram?
I would order a discogram if you're looking to get more of a specific picture image looking at the absorption of the disc itself. Correct? Look for herniation, looking for any progressive degenerative nature. I mean, you're just looking for a more specific look at the disc itself. That's
So don't be compelled to order a discogram because that requires a lot more consideration.
okay.
No, the way I talk to my patient, have you had a flat tire?
Mm-hmm.
Okay. What happens if you jack up your flat tire? What happens to the tire? It looks normal again, right?
Mm-hmm.
There are some discs, some patient that they have horrible back pain, but when they lay down, and that's the point, they lay down to get an X-ray, CT, or MRI or CT, and the disc look normal because there's no pressure on it. You want to provoke those discs to see if symptoms are very, very representative, but the CT and MRI are not really, don't look super bad. You have an idea, but they don't look really super bad, You want to provoke those discs individually to see if under pressure, they provoke the same pain. So, and you have seen some of those discograms that we do, right?
Yes.
Put individual needle inside of the disc, then we increase the pressure. Now, there are two camps in spine surgeons. There's a camp that they don't believe in discogram. There's a camp that's almost half-half. There's a camp that they absolutely love it. I absolutely love it. Because those camps that they don't believe in discogram, they just look at the film, tell to the patient, get out of my office. You're a faker. There's no problem there. You just want a medication. And I'm being very harsh to them, but they deserve that. Themselves. The X-ray problem, but the pain is 10, they consequently assume that patient is pretending or lying. Okay? Whereas I don't leave any stone unturned. If X-ray doesn't correspond to your symptoms, I give always the patient the benefit of the doubt that you are right. Let's look for a reason why the pain is 10, but MRI only would justify 3 of 10 pain. Okay? But it would make it really easy for the surgeon. So, MRI shows a little bad thing, but this would no way explain 10 of 10 pain. So get out of my office. I don't want to bother with that. In truth, those are the patients, they come to us, they tell us they saw 5 surgeons and they told them nothing is wrong with them, nothing can be done with them. Then we investigate them, we fix them, they come off narcotic within weeks, they regain their life because nobody bothered to really investigate them thoroughly. So let's go back to discogram. We provoke the individual disc to see number 1. If we put contrast in this under pressure, if it leaks out and if there's 1 hole or 20 holes. Literally, there are people, you see 1 hole, there are people who slashed open, the disc slashed open. Then we see because we put contrast and we can look at it with CT and X-ray, we can see if that contrast goes toward the nerve, the foramen or spinal canal, or away from the nerve. Then we ask the patient, in the moment we increase the pressure, does the pain get worse? And if it's getting worse, is it same pain or different pain? And we don't even stop there. We pressurize a normal disc and see how a normal disc look like. Like if I pressurize a normal disc and patient screams, yeah, pain, 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 and the disc look normal, then that is as well, like a red flag for us. Okay, so we use a control level. And on top of that as well, we can do that individually for each disc separately. So if 5 discs look bad, sometimes I use discogram to narrow it down from 5 discs to 2 discs. that I can give the patient the best benefit. So many times I use the discogram not to do the surgery, but to do a smaller surgery. Very powerful tool. So let's go back now, one down on the test side. Functional test, ODI, and so on and so forth. Why is that important
Can you read it?
What-
in our protocol?
Says
Yeah, what is the RM?
Auspes-3 Disability Index.
Yes, I see that. I see that most often with our PT notes per se, when we send them off to physical therapy. But basically, again, that's the testing the function of how your patient is able to do these. Typically, we get a baseline number and then we're able to see what their level is afterwards. And that's how I compare their level of functionality.
Compare. You are using the right words. I like it. Compare. You send them to physical therapy. They come back and say, I hated that. It doesn't work. And then, but you look at the ODI, it's getting better. Keep going. Okay. This is the closest we are to be independent. We have objective kind of measurements of their improvement. And then obviously psychological issues are important. You have to address them. And then on the bottom, you see something in our protocol, we call it Karnofsky index. What is Karnofsky index?
I know I've read this, but I'm not going to be able
to. In cancer is used. It's about like, you are probably 100% Karnofsky. I am probably 90. And that some of Amanda's friends brought the baseline is like 20.
Hey,
that
they're
is a
young.
joke. That is a joke only neurosurgeon understand. So Karnofsky index is how functional you are. Okay?
Okay.
Why is it important for our decision-making process regarding surgery?
Well, we need to be, for a lot of different reasons. One, we need to have the patient be aware of the decisions that they're making, as well as being able to get an actual representation of what's going on at the time as well.
That is the psychological status, not the Karnofsky.
Oh, okay. Maybe I'm confused.
Yes, Karnofsky index is about like, can you walk? Can you eat? Can you do basic things and so on? How sick are you? Are we going to go do a big surgery on somebody who's very, very sick, is pre-mortem at the Karnofsky index of 20, 30?
Not as likely. Yeah.
No, we won't. Okay. But if your Karnofsky index is 80, 90, 100, we are more likely to be able to help you with the surgery. So we will give you an option of the surgery. Lower the Karnofsky index is, less likely is that you would benefit from a surgery. And surgery would put you over the, over the top and, make you.
Is that a chart that we have in our protocols?
So that is why it's part of our protocols.
Okay. So yes.
Say one more time.
No, sorry, we cut out. I was asking just that. I said, is there a scale on our protocols or some sort of, numbering system that we document that to? The Kofsky.
So you see that there? This is the second page of our multidimensional protocol, which explain what those things really mean. I'm not going to go to the bottom of it.
That's okay. That's okay.
But
I've seen that, so I'll refer to it.
Things that you learned today is what are the red flags, which are red in our protocol, look for. You see top to bottom, or bottom to top, they become more important. And the spatial representation, when you come to the bottom, they are farther away from the zone 0. Zone 0 is direct to surgery. Zone 4, just do whatever you like. Do physical therapy, do the supportive measures, bracing, and so on. Consult zone, which is 1, 2, and 3, is depending on your level of experience. If you're very experienced, you can go all the way to zone 1 before you consult. But if you're not, if you're just starting your career, get a consult with zone 3. Nothing wrong with that. Okay. So, but consult zone, which is zone 1, 2, 3. Now, zone 0 is a must. You don't have a choice. You see any of those red signs with corresponding thing, you pick up the phone and you call.
You say, luckily, I've seen quite a few zone 4s and no zone 0s yet. But 1, 2, and 3, I've seen a couple that I talk about that they're ready to see you as soon as I am. So I just want to make sure, I'm getting them with the right things that they need. So for sure, C2 milos are the ones that we're going to start. But
no, but what do you do in the patient like that? You always send them for physical therapy.
Yep, I always give them.
You put the supportive things. If you know which one, even order some injections. Nothing wrong with that, depending on where your experience level is. And then you get imaging, you do conservative management, you do imaging, proper imaging, and then you send them to me. Then they're in the consult zone.
Yep.
And what you don't do is that somebody who's unstable, put the acupuncture on somebody who has myelopathy is unstable. You don't do that. As well, what you don't do is somebody who has just a little bit of a pain, send it directly to the surgeon, because we know you almost tripling their chance of getting a surgery. If somebody has symptoms that warrant zone 4 and 3, but you send them prematurely to a surgeon, you are doubling, tripling their chance of getting unnecessary surgery. So the rest is discretion, obviously. But having said that, that's actually practically it. It's not really hard. As a matter of fact, no, it is hard. But if you follow what we just talked about and the multidimensional protocol, and we are not going to go to the bottom half of the protocol, let's just call it a date right now, then you're good. Then you are a safe person to triage almost 99.9% of the spine.
I was to say, I think you did a really good job. That's the importance that you're saying, is we're not trying to determine whether someone needs surgery or not needs surgery with this per se. We're trying to get them to the right people with the right path, with the right things at the most efficient way possible. You know, this isn't meant to tell somebody that they have to have surgery or they don't have to have surgery. It's I just wanted to point that out there too.
Yeah, it's an organization.
Our algorithm. We love that.
Yeah. And trying to unify that if they're in Kansas, Texas, California, here, and so on, that all of us will use the same protocols. Have a grand unified approach to this. Do you know why it's important, Amanda? That is actually a sad story. Why this is important? Imagine there are lots of things can be wrong with your spine, right?
Yeah.
The kind of treatment you get is nothing to do with what kind of problem you have. It has all to do who do you see first.
Right.
Yeah. Well, we know that all too well.
Yeah. If you see a interventionalist versus a spine surgeon, and what kind of spine surgeon, independent of what problem you have, the most indicative of what kind of treatment you get is who you see first. We are trying to overcome that human bias that I'm a surgeon, I just want to do surgery. Or that person is acupuncturist, he just want to do acupuncture on an unstable spine. Or that person is a interventionalist, you just want to do injection or spinal cord stimulation device on somebody with a 60 degree.
Yeah. It really unifies everything for sure. I think it's a really helpful tool to have.
And but as well, our goal is to reduce the number of the surgeries that we perform. That's why our goal, you see that 5% on the bottom, that is our goal. We are not there yet. We are at 8.2%, but we are still twice as conservative as any other surgeon out there. Okay. Well, let's call it a day. This was actually, I enjoyed that.
Yeah.
Especially that the first time I can make fun of you guys. Usually
no kidding.
You make fun of me.
I thought I was a little brain dead before hitting this podcast at 4:00. Now I'm going to go home and have to take a siesta. Thanks, guys.
Yeah. It's not your first time making fun of us either, by the way.
Well, I love you guys anyway. So don't take it.
I guess it's mutual.
Yeah, whatever.
Okay. Well, thank you very much for everybody to join us.
Thanks for joining. My name is Amanda Armagoss.
My name is Alyssa Haber.
And I'm Dr. Abbasi for Essence. And please make sure everybody get this podcast and start as well using it. Thank you.
Thanks,
you.
guys. Be safe.
Bye-bye.